Hello, and welcome to today's webinar on approaches to manage alert fatigue and suggestions for appropriate metrics. My name is Dr. Joseph Catino, and I am a trauma critical care surgeon and director of the Trauma Intensive Care Unit at Delray Medical Center in Delray Beach, Florida. A recording of today's presentation will be available on FCCM's YouTube channel within 3 business days. Please take advantage of this resource to further educate your colleagues. The webcast today is brought to you in collaboration with the Surgery Patient Safety Committee at FCCM. Before we get started, a bit of housekeeping items. There will be a question and answer session at the end of our call. If you have a contributional question, please type it into the question box located on your control panel. Questions will be addressed at the end of the session. Today's presentation also will include an interactive audience poll. Answer by clicking the bubbles next to your choice. Now it's my pleasure to introduce our faculty for today's webcast. Dr. Sandra Kane-Gill is Associate Professor of Pharmacy and Therapeutics at the University of Pittsburgh School of Pharmacy in Pittsburgh, Pennsylvania. She has secondary appointments in the School of Medicine and the Clinical Translational Science Institute, Department of Critical Care Medicine, and Department of Biomedical Informatics. She also serves as Associate Professor for the Center for Critical Care Nephrology and Center for Pharmaceutical Policy and Prescribing. In addition to her academic appointments, Dr. Kane-Gill is Critical Care Medicine Safety Pharmacist at the University of Pittsburgh Medical Center in the Department of Pharmacy. Dr. Kane-Gill has been funded by the Gordon and Betty Moore Foundation and served as co-chair for the FCCM Alert and Alarm Fatigue Task Force. Now I will turn over the program to Sandra.
Thank you, Joseph, and thank you to the Patient Safety Subcommittee of the Surgery Section for organizing this webinar. Today we're going to be discussing alerts and alert fatigue, and I wanted to begin by just clarifying what I'm considering to be an alert. An alert would be a warning or an informational pop-up that's generated after criteria for a signal have been met. So basically, you may have clinical decision support within your electronic health record, or you may have some type of an independent clinical decision support tool. And so somewhere lurking in that electronic health record, there's criteria that somebody has developed. And once those criteria for those rules have been met, then an alert is generated and then sent to the clinician either via a pop-up on the computer, or maybe it's sent to their pager or their cell phone. So I know everybody has had the pleasure of being exposed to alerts. We're using alerts a lot more frequently lately. They're even being used for situations such as early warning signals for patients who might be developing sepsis or acute kidney injury. But most oftentimes we'll see alerts that are generated when a medication order is being processed or during the medication order verification process. It seems anymore when we have a clinical problem that can be possibly solved by a consistent electronic evaluation that we have a tendency to develop an alert for it. In fact, there's regulatory bodies that are encouraging the use of technology. In this situation, the Health Information Technology for Economic and Clinical Health, or the HITECH Act, began in 2009 and encouraged institutions to adopt an electronic health record, providing financial incentives for hospitals to engage in meaningful use to improve care delivery. I'm going to talk about the HITECH Act in a little bit more detail here. So the HITECH Act actually has 3 stages. As I mentioned, it began in 2009 with stage 1, which was focused on the goal of capturing and sharing data, such as the implementation of an electronic health record, or CPOE, which is computerized prescriber order entry. Then stage 2 is an advancement of that, which involved the advancement of clinical processes, such as electronic prescribing. Then moving on to further advancements, which was stage 3, focused on improving quality and safety and efficiency of the electronic health record, with the ultimate goal to improve patient care. And this is where clinical decision support comes into play. Overall, clinical decision support is a general requirement for meaningful use, but the Joint Commission also has set a standard requiring institutions to employ at least one clinical decision support tool to meet their standards. So overall, we know that electronic health records are increasing, clinical decision support is increasing. In fact, a national survey of about 1,400 hospitals indicates that 92% of those respondents had either partially or completely implemented an electronic health record. And the use of the CPOE in clinical decision support is also on the rise, with about 65% of respondents to that survey indicating that they had some form of CPOE or clinical decision support. So I wanted to go through the terms and definitions that I'll be talking about today, just to make sure that there's some consistency for understanding purposes. I'd already mentioned the word signal when I was describing an alert, and a signal is a clue suggesting the presence of an adverse event. So that helps that that signal is put into place for the rules and the knowledge that's behind the alert generation. I mentioned what an alert is, and then the definition for alert fatigue is to describe, it describes how clinicians become desensitized, right? They receive so many alerts, they become immune to the alerts and really just continue to get through them so quickly by bypassing them. But at some point in time, there's the opportunity that they're bypassing them so quickly that this could result in overlooking a clinically significant alert. And an alert override is the bypassing of the alert. And then there's a term to introduce here, which is alert value. So we're pretty astonished when we hear the fact that maybe 90 or 95% of alerts are overridden. But I think we need to pause and consider that maybe it's appropriate to override those alerts. Maybe our alerts aren't performing very well. And so if they're not performing well, then it was an appropriate reaction to override that alert. But if you're providing a valuable alert, then a valuable alert is one that could flag the attention of the clinician in a timely fashion and actually appropriately clues them in for the need for an intervention. I've already mentioned the term electronic health record, and so that's just basically the electronic version of the patient's medical record. And then CPOE and clinical decision support are often discussed together and sometimes used synonymously, although they're not. CPOE is really just that, which is the prescriber order entry, where clinical decision support is the system that's designed to help the clinician in the decision-making process. So I wanted to ask the audience if they could complete the following statement. I feel my optimal performance as a clinician is inhibited by the number of alerts that I receive, enhanced by the number of alerts that I receive, or inhibited and enhanced by the number of alerts that I receive. So very interesting. Some people actually find that the alerts are just inhibitory. They're getting in their way. They're not helping them to be productive. While other people can see a benefit to both, is maybe inhibiting your performance, but also enhancing your performance. Quite interestingly, nobody said enhancing only. So interesting responses there. So there are negative consequences associated with alert fatigue. And as you can imagine, with all the alerts that you receive, that it's easy to become frustrated, right? You get so many that it's inhibiting your workflow, that it's not allowing you to progress with processing that order, so it would cause frustration. It can also be a waste of time potentially, right? Especially if you get, in your institution might have alerts that requires a forced response, meaning you can't proceed or override that alert until you provide a reason in which you're overriding the alert. And so sometimes that takes a delay in your ability to process or continue with your workflow. So that could be deemed as a waste of time. And of course, the true definition of alert fatigue is the fact that you become desensitized and you potentially overlook a clinically meaningful alert. So we're going to talk about each one of these in a little bit more detail. So this was a survey that was conducted at the VA for primary care physicians. It was sent to 5,000 primary care physicians, and there was greater than a 50% response. The goal of the survey was to determine the physician's satisfaction with the alerting system and even to see if the alerting system might be encouraging them to seek employment elsewhere. And what was noted with those providers who didn't perceive value in the alerting system, they actually became more dissatisfied with their job and actually did prompt them to want to seek employment elsewhere. That's a pretty significant impact associated with alert fatigue, wanting someone to uproot their current position and to do something else at another facility. Other comments that had been made from the survey were that the alerts were causing that the physicians were actually having to do tasks that they hadn't normally performed, that were actually typically done by a staff member, and now the physician was having to perform these tasks, which was causing them to delay the time to process an order or continue in that particular workflow. So really a negative feeling associated with the number of alerts that they were receiving. Another potential negative effect is the delay in processing of orders. This was an evaluation that was done at a hospital in Pennsylvania that specifically looked at one drug interaction. The drug interaction was warfarin and trimethoprim sulfamethoxazole. What they felt was at their institution that this drug combination, which causes a risk for bleeding, was being used too frequently at their institution. So what they wanted to do was to put in a forced response alert. The clinician who was entering the order could not proceed with the order because it had a hard stop on it. So they performed this evaluation at 2 medical centers and included about 2,000 clinicians. And half of the clinicians were randomized to a nearly hard stop alert. And the nearly hard stop alert meant, again, they couldn't prescribe those 2 drugs simultaneously, except for under 2 conditions. One, the patient had PCP or pneumocystis carinii pneumonia, or the other option was that they felt that it was clinically necessary for the patient to have this. They'd have to call the pharmacist, and so the pharmacist could help them to override it. So those were the two circumstances in which it could be overrode. The other half of the physicians received basically contact by the pharmacist. The pharmacist would receive the alert. They would adjudicate the alert, and then as necessary would contact the physician with a recommendation. So you can see that in the adjudicated alert group, they would receive less alerts than in the nearly hard stop alert group. So what ended up happening with this study was it was terminated early because of the delay in the ability to process the order. This hard stop and the number of alerts they were seeing delayed them from actually processing the order, and it resulted in negative consequences for 4 patients who were delayed in either getting their warfarin or their trimethoprim sulfamethoxazole. There was another study that evaluated alerts, said, okay, depending on how many alerts the clinician receives, what would be their amount of time to process those alerts? And what was noticed was the more alerts a clinician received, the dwell time or the evaluation time for those alerts decreased. And the thought was this was due to alert fatigue or becoming immune or desensitized to the alerts. Another potential negative consequence is mismanagement of alerts, right? So in this particular evaluation, it was for 18 medical residents, and they underwent a simulation for 6 different patient case scenarios. And these 6 patient case scenarios resulted in 211 drug-related safety alerts. And after they were done their simulation, the alerts were evaluated for appropriate or inappropriate response. And it was noticed that in approximately 1/3 of the alerts that the residents didn't handle them appropriately. And by definition, inappropriately was either an incorrect action was taken or an incorrect reason was provided for the override. And in a post-survey evaluation of the residents, they indicated that they felt that part of the reason for their mismanagement was due to alert fatigue. The next statement I'd like for you to respond to is you feel, in general, the number of alerts that you receive at your institution is too many, just right, or too little. So the majority of individuals really believe that they're receiving too many alerts, and that's pretty consistent interpretation with many clinicians at many institutions. So the Society of Critical Care Medicine received a grant from the Gordon and Betty Moore Foundation to evaluate which approaches had been used or which interventions had been used to reduce alert fatigue and to provide critical care clinicians with some guidance on managing alert fatigue at their institutions. So what I'm presenting today is a worked product of the Alert and Alarm Fatigue Task Force, in which we conducted a thorough evaluation of the literature to come up with some recommendations for management. The manuscript is currently under review at Critical Care Medicine. And one of the things you'll notice with our evaluation is that I'm going to be discussing a lot of clinical decision support that's related to medications, but that wasn't what our search criteria was. Our goal was to evaluate any clinical decision support. Just coincidentally, a lot of the literature that was available was specific to medications. Also of note, before we proceeded, we discussed the ability to measure alert fatigue and realized it's actually kind of challenging if you think about trying to measure desensitization and how that might be measured. You can imagine that not a lot of studies could or would have done that. So a priori in our search, we decided to look at interventions that reduced alert quantity with the intent of reducing alert fatigue. So you'll notice that a lot of the studies I'll talk about is reduction in alert quantity. So some of the studies that I'm presenting here, there's 7 different types of options for interventions to reduce alert fatigue. And at the bottom on the left here is selecting a commercially available system. That would be one of the first steps to consider. The second one is to customize that commercially available system. Thirdly, you could get a ton of drug interaction alerts that are really false positives. They're not accurately identifying or maybe not clinically relevant. And so taking some interventions to reduce the number of drug interaction alerts. Focusing on an intervention that uses alerts only for rare or atypical events. An intervention that suggests, you know what, let's ask the physician what alerts they want to receive and what would be the effects of that. And then, of course, making a more sophisticated or smarter alert. If you get a highly performing alert, then clinicians are more likely to respond. If I said to you, look, at every alert you're going to get, I am 80% confident that it is going to require some type of an intervention. I have your attention, but when I tell you that out of 100 alerts you're going to receive, one of them is clinically relevant, you can see why you feel like you have too many alerts. Another option for an intervention is learning from alert overrides and information with regards to alert overrides. So we're going to begin by reviewing the information on selecting a commercially available system. So the first thing to realize is that when you select a commercially available clinical decision support system, that all systems are not created equal. And there are a couple of studies that have evaluated and compared alert generation amongst different clinical decision support systems. And I'm going to review one of those. So this was an evaluation of 3 different clinical decision support systems, System A, System B, and System C. The system ran amongst the same 100 patients. And in System A, there was 53 alerts generated. System B, 328. And System C, 362. So in System C, there were 7 times more alerts than System A. Now, when a clinician went back and evaluated the clinical relevance of these alerts, 5.7% were considered clinically relevant for System A, 7.6% for System B, and 8% for System C. Overall, out of all 3 systems, 33 alerts were judged to be clinically significant. So despite the fact that you had 7 times more alerts, you didn't have 7 times more clinically relevant alerts. So that's where the performance could be improved. So this study wasn't specifically an intervention around alert reduction, but it did indicate that if you look at a clinical decision support system, that inherently one may generate more or less alerts. So the key here is that, when you think about implementing a clinical decision support system at your institution, you need to ask a few questions before you do it. And it's not just around cost, right? Not just how much is this system going to cost me, but how well does it perform? right? If I put the system in place, how frequent are alerts going to be? If I put the system in place, basically, for every alert I receive, how often does it detect a true clinically relevant event? So how well does it perform? And then if it still results in a lot of noise or too frequent alerts, your question would be, do I have the ability to make modifications? Are the modifications and the rules around the alert generation easy to be modified? Can anybody do it? Can we do it? And can we, basically help to make performance of that alert specific to our institution? So thinking about customizing the commercially available systems, which I just mentioned, let's think about a study that did just that. This was an evaluation at an institution that specifically looked at new single-dose limits. So at UPMC, we have an alert that if the patient is greater than 70 years of age and they receive a single-dose order for morphine IV that exceeds 3 milligrams, then an alert is generated and says, you know what, do you really want this dose in this individual? And so they focused on single-dose limits within their alerting system. And the drugs that most commonly generated single doses at their institution were drugs such as glycopyrrolate, heparin, dexamethasone, morphine, and propofol and vecuronium. So they said, you know what, let's alter the thresholds for these particular alerts. And there may be some leeway in the creatinine clearance calculation. So instead of going by the exact creatinine clearance that we have, let's allow an increase of 20%. So if a patient had a creatinine clearance of 45 and the alert or the rule behind that alert said that, you know what, this is drug dosing for this particular drug needs to be modified if the creatinine clearance is less than 50 mils per minute. This patient having a creatinine clearance of 45, they would have generated an alert. But allowing this 20% leeway, that 45 then becomes 54 mils, and the alert would not have been generated. So this is their goal and the means in which they're trying to reduce the number of alerts. They also said, you know what, there's some errors in the way that, in the accuracy of weights that are available in their computer system. So allow some leeway of 20% for the weight that was entered, or if the single dose range is based on weight, then they had a plus or minus 5% rule. And also, if they had duplicate alerts, so if they had the same alert for the same patient, for the same drug, for the same dose, for the same route, for the same frequency, that was generated within a week's time of the first alert, then that would be suppressed. We sometimes have that. We have this noisy alert for hypoglycemia that you get a hypoglycemia alert, you decide that you want to make an insulin adjustment, but within less than 24 hours you're getting another alert, but you haven't even had time to have your insulin adjustment go into effect for the patient to potentially rectify the situation. So having those types of alerts so close together, sometimes it makes sense to suppress those until the right time. In this case, they chose 7 days. So they implemented these changes at Hospital A, which is an 850-bed academic institution. And when a single dose order occurred in the pre-implementation phase, about 12% of orders generated an alert. After they made these changes, that was reduced to 0.6%. At Hospital B, this was a 460-bed community hospital, and when single dose orders were generated there, they resulted in about 6% having alerts. And so after the change, though, after these changes they put into effect, there was a 0.8% of orders had an alert. So you can see these changes did have an effect on the number of alerts. Now, we don't know that they had if it resulted in any negative consequences for patient outcomes, but it did result in alert reduction. So moving on to thinking about modifying drug interaction and allergy alerts. Again, as I mentioned previously, there's just a lot of noise around drug interaction alerts. And so the need to modify those to make sure that they're better performing is important to reduce the noise. So this is an evaluation that was conducted in 484 patients. They had 2,800 prescriptions. And this commercially available system that they had showed that when the severity ranking for a drug interaction was in the top 2 categories of high and average, then 40% of patients fell into this basically top 2 categories of severity. So what they said was there's actually a published severity scale and available, and so why not relook at how these drug interactions are ranked on severity? Use this particularly new scale. It actually has 4 criteria: contraindicated, provisionally contraindicated, conditional risk or minimal risk, and look at that same set of patients and how often that they would have resulted in basically contraindicated or provisionally contraindicated alerts. So that reduced this number to 6.2% of patients in those top 2 categories. So if clinicians only received alerts around the most severe drug interactions, then this would have reduced the number of alerts that the patient or that the clinician received. So thinking about drug allergy alerts, this particular institution is a health system in California said, you know what, we have so many overrides associated with our drug allergy alerts, and we think that number is too high. So they wanted to put in place a requirement, a forced response for the clinician to respond to these allergy alerts before they could proceed. But they thought, you know what, we have so many alerts, we need to refine this before we put in that forced response. So one of the things that they did was said, instead of sending physicians alerts around allergies that weren't related to reactions for anaphylaxis, that those would be removed, because oftentimes those drugs would have been prescribed anyways. So the alerts where an allergy alert was generated and the patient's reaction was actually diarrhea, lightheadedness, anxiety, or nausea, those ones were reduced, or those ones were dismissed, and they weren't sent to the physician. The other thing they noticed was that alerts were alert information that was entered into the electronic health record was not always accurate, that the individuals inputting that information did not necessarily have the skill set to appropriately contribute the correct information. So they limited the ability to enter allergy information to pharmacists, physicians, and nurses. The other thing they noticed was a number of their overrides were really around inactive ingredients. So this is where they actually had this text box for inactive ingredients, and a lot of times that misinformation or non-clear information was put in there. So food allergies were actually being put into the inactive ingredient text box. So if the patient had an allergy to a banana, that was entered. And since the computer system couldn't match up that drug had anything to do with that inactive ingredient of banana, the alert was oversensitive and generated an alert for the clinician to evaluate. So they removed inactive ingredient alerts. And so these changes actually resulted in a 64% reduction in their alerts. So moving on to think about alerts just focused on alerts generated just for atypical medication orders or for rare events. This was an evaluation that was done at the University of Michigan that actually looked at saying, you know what, we have a drug dosing software alerts, and every time there's a drug dosing software alert, it's not always accurate. And so maybe we shouldn't focus on the drug dosing software that's inherent within our clinical decision support system. Let's instead go look for atypical drug dosing orders. So they went back and looked at all their historical data and said any new order that's put in place that doesn't look similar to an order that had been processed in the past, that would be considered an atypical order. And if we just focus on these atypical medication orders, could we reduce the number of alerts and maybe give more clinically meaningful alerts? So they only focused on 5 particular drugs: calcium, clopidogrel, heparin, magnesium, and potassium. And with this idea of using and focusing on atypical alerts, 68 alerts were generated in a 92-day period for 18,000 orders. and this was about half of what had been generated during a similar time frame previously. So they felt this to be a success in their alert reduction. So moving on to think about physicians' preference for alert selection. So why not go ahead and ask the physician, like this is a pretty straightforward way of reducing the number of alerts a physician is going to receive, is if we ask them what alerts they want to receive, or actually give them an on-demand system that allows them to have the alerts running in the background, and they can access alerts whenever they feel appropriate. So this was actually a randomized trial of 28 physicians in primary care practice, and 14 of the physicians were entered into the on-demand group. So they didn't get alerts sent to them. Again, it was running in the background. They could access the alerts at will. Versus the other 14 physicians who received alerts, but it was dependent on the severity level they chose. So if they wanted alerts for only severe events, they got all alerts around severe events. If they wanted only alerts for moderate to severe, then they would receive all alerts that met that severity level. So overall, in the on-demand group, running in the background, there were 4,500 prescribing problems that occurred. And physicians opted to look at 41 of those. So just less than 1% were evaluated. And if you look at the more inclusive alerting system, where the physicians received many more, there were 6,500 prescribing problems, and the physicians opted to investigate or open up and evaluate about 668 of those alerts. So more closer to about 10% were actually evaluated by the physician. So, you know, by definition, in allowing the physician to select what types of alerts they wanted to receive, there was alert reduction. Making a more sophisticated alert. So, you know, the problem is that oftentimes that the alerts aren't clinically meaningful that people receive. So that is where this frustration comes into play, that they're having to evaluate alerts that typically aren't clinically meaningful. But if we developed a more sophisticated alert, if they were better performing alerts, smarter alerts, and you had better confidence that they were going to actually evaluate and identify a situation that actually required intervention, then it's likely that individuals would be more responsive to that. So this was an evaluation of two different systems, the first being their conventional system, in which the pharmacist actually performed surveillance by looking at drug interaction and drug overdosing alerts that had been overridden by the physician. So they looked at, in the next 24 hours after the alert had been overridden, was that appropriate? If it wasn't appropriate, then they'd reach out to the physician to make a recommendation. The new system actually involved combining data, and so instead of having the pharmacist do this risk evaluation, they would make a better performing alert by combining data from the patient's file, including laboratory data and patient characteristics. And the goal was that if this was a better performing surveillance system, we'd have less alerts. So they ran these two systems on the same patients retrospectively over a month period of time, and found, and this was hospital-wide, and they found out that the number of alerts generated per day for the conventional system was 75, and there were 10 less alerts per day with this new surveillance system. We said, okay, let's take a deeper dive and take a closer look at this comparison of systems. And they looked at 6 months worth of data prospectively for just the internal medicine unit. And over that 6-month period of time, the conventional system generated 177 alerts, of which later 136 were deemed to be true positives. And the new surveillance system had generated 248 alerts, and 72 were deemed to be truly clinically relevant alerts. So interestingly, when they looked at the retrospective data hospital-wide, it looked like this new system, this new approach, was going to be beneficial in reducing the quantity of alerts. But looking at the prospective evaluation in one particular unit, that did not yield the same results. So this is just a summary of suggestions on how to develop advanced alerts or alerts that are more specific for a particular event. This is information from the ADKI group, which is the Acute Dialysis and Quality Initiative. This particular group gets together and has a conference, and they discuss a certain topic, and they make recommendations from that conference. So this particular conference was around big data, and the goal was for early detection of acute kidney injury. And what they propose to make an advanced alert is basically, go to literature here and do this feature selection, which is going to literature, identifying risk factors that were available in the literature to develop an alert that takes into account these risk factors for early identification of acute kidney injury. But you know what? Let's make sure before you put it in place that we develop this model and test this model to see if it will perform well at our institution, right? And so make sure it's performing well at each individual institution before adopted. And then, with that information that you have for your institution, you might want to tweak it before you actually, have it available to clinicians. And then once it is available to clinicians and you integrate it within your electronic health record, remember this is a dynamic model, meaning you don't want to just set those risk factors and forget them. You may want and find information that's specific to your institution. And so having a machine learning process and a way to adapt the current alert, learning from the information that's available while the alert is running can help you to continuously modify that alert and to enhance its performance over time. So it looks like that's the way we're going when we truly want a high-performing alert, and hopefully we'll be seeing that in the future. Another, the seventh proposed intervention to reduce alert quantity to manage alert fatigue is learning from the information we have, learning from alert overrides. I think this was an interesting evaluation in the sense that it was an evaluation to figure out, these alerts are always overridden. It's the same alerts that are overridden. And so if we know that these alerts are always overridden, that they're not useful, why not develop an algorithm that filters out those commonly overridden alerts? And so that's what they did. They went ahead and developed an algorithm using a training data set for alerts that should be typically overridden, and so they would be filtered out. So the clinician wouldn't see those alerts. And then information, they actually went into a test data set to see how well this algorithm performed and realized that the particular algorithm, or the alerts that were generated during the 3-month time frame were about 6,000 alerts. But if the alerts had been filtered out using this algorithm, there would have been a 27% reduction in the number of alerts. That seems pretty useful. But there were still 4,420 alerts that were not filtered, and the clinician still would have overridden them. So this still had an opportunity to continue to refine this algorithm to reduce the number of alerts that were continuously overridden. But it seems to be a step in the right direction. So when we think about reducing alert quantity, it's a balancing act. When I started, I said, high alert quantity, alert fatigue results in negative consequences such as, frustration and job dissatisfaction. It could delay the processing of an order. You could have been desensitized so much that you overlook a clinically relevant alert. But the reason why we put these systems in place, right, when we had no alerts, the reason why we put these alerts in place is because we felt that they were offering some safety, some enhanced clinical performance, right? We saw some value when I answered the first questions that I'd asked you. Felt some value associated with alerts, and that's why we put them in place to begin with. So this is a balancing act between what's too many alerts and what's too few alerts. And in either way, safety is on each side of that scale. So there are some negative consequences associated with too few alerts. And going back to the evaluation that I mentioned, which was comparing 3 commercially available systems, I had said that System A had 53 alerts generated, and System C had 362 alerts generated, seven times more alerts generated with System C. And I also had said that there were 33 alerts judged to be clinically significant. Well, System A had identified 9% of those alerts that were judged to be clinically significant, while System C had identified 88% of them. So while you had many more alerts with System C, it also did identify more clinically significant events versus System A. So using just System A, you would have had less alerts, but you would have overlooked some clinically meaningful alerts. Going back and thinking about the system that I'd mentioned, which focused on just looking at rare medication orders or atypical orders, I had said that there were 68 alerts generated over a 92-day period. That was felt to be a success because it was about a 50% reduction from what they were used to previously. Still, even with 68 alerts, 50 of them were overridden. So despite the fact that there was fewer alerts in that 92-day period, there were still many that were overridden. And then the evaluation came into play was, should they have been overridden? And it looked like that for 20% of them, despite the fact that it was overridden, the clinician had made some change in the patient's medication. And then, but for 50% of the ones that were overridden, the problem wasn't averted. They overrode it and didn't appropriately make any change whatsoever. So interestingly, despite the fact that there was fewer alerts, there was still a high number of overrides and potentially overlooking a clinically significant event. Going back to think about the physician selection of alerts, this study where I mentioned, which was 28 physicians from a primary care practice, and I had said that they only looked at 1% of alerts were chosen to be looked at by the clinician. They did result in 31 problems being resolved. So it did yield, like when they felt that it was necessary to look and obtain additional data and look at the alert, oftentimes that did result in some type of change for the patient's care. And then with the more inclusive alerting system, where the physicians looked at many more alerts, that resulted in more resolution of problems. So this was less alerts and resolving less problems. This was more alerts but resolving more problems. So you do have the opportunity to, when you reduce the alert quantity, to overlook a clinically significant event. This was a study that I mentioned with the algorithm, learning from our overrides. And when you learn from the overrides, this was the 6,000 alerts over the 3-month period in the test data, and 27.4% were filtered out with the algorithm. And this one was the 4,000 that were unfiltered, but still a good chunk of them were overridden. So this was presenting an opportunity for continued refinement in the algorithm to reduce alerts that may not be meaningful. Still, the filtered group had 106 alerts that would not have been overridden by the clinician. So this, you can see, is an opportunity that where clinically relevant alerts would have been overlooked. So the next question I have for the group is, how well do you expect clinical decision support alerts to function, to find utility within the system? Do you think for every 10 alerts that you receive, that having one that's clinically useful is a good number, is a reasonable number for you? Or for every 10 alerts that you receive, that having 3 that were clinically significant is a reasonable number to find utility in the system, which is 30%. Or for every 10 alerts that you receive, that 50% of the time that it was resulted in a clinically significant event? Or is it 7 out of 10 that's a reasonable number for you? Or do you expect more than that? Do you expect a really high-performing alert to find it useful? So quite interesting. There's a large variation in responses here. That some people want a pure, like a very high-functioning alert. They, greater than 70%. They want greater than 70% accuracy in the alerts that they're going to be receiving. But overall, the rest of the group seem to be around this 50 to 70%. So this gets us into asking, what's the ideal number of alerts? I said it's a balancing act between too many and too few, but what would be the ideal number that we should be targeting? And unfortunately, there's no useful study that has evaluated that. There was a narrative that suggested that for every 100 medication orders, 10 alerts would be a reasonable number. And that was where they believed that physicians' behaviors would change, that they would be receptive to performing some type of an intervention, although that seemed more of a narrative and not based on any actual data. There was another study that said and alluded to the fact that clinicians want to have at least 70% of alerts that are appropriate, that perform well, to maintain their confidence in the system. And that was actually interesting that there was a similar number to what the respondents were on this particular survey, and you all said that, you know, the good majority said 70% or above. So I mentioned that the limitations to the studies or when I started, I said, you know, when we were evaluating metrics, we went forth and looked at alert quantity because we knew it would be hard to measure desensitization. And alert quantity is only one component of alert fatigue. What I've alluded to is that when there are overrides, and we hear 95% of alerts are overridden, it seems that you should do a further evaluation to see if that was inappropriate overriding or appropriate overriding. Basically, do these alerts have value? That means it's an override that's inappropriate meant that was value in that alert despite the fact that it was overridden. And how do we measure clinicians' desensitization? A little bit hard. There's one study that actually suggested how to measure desensitization. And this study suggested that it was evaluating desensitization was in terms of mental workload in an overwhelming situation. And they proposed two particular instruments that could help with the evaluation of desensitization, which is subjective workload assessment technique and the National Aeronautics and Space Administration Task Load Index. So these two instruments would help to measure desensitization. And going forward, I think we need to think beyond just reduction in alert quantity and think about alert value, and also think about when does desensitization come into play. Remember, I mentioned that study, significant reduction in alerts, but still, even with a low number of 68 over a 92-day period, 50% were being overridden. So was that really desensitization, or what was the reason for that? So just to briefly mention, show me the money, what's the return on the investment for all these systems? And basically, I'm just going to talk about three studies briefly with regards to starting on a top-down approach from a national perspective, institutional, and ICU perspective. The trade-off in predicting cost and benefit for the United States when it was heard that, you know, this high-tech act was going to play, would this be financially lucrative, or how much would this cost the United States to put all of these institutions with an electronic health record? And the costs that were considered were purchasing, training, and maintenance costs. And overall, if 20% of institutions had already had an electronic health record, it would cost the United States $98 billion over a 15-year period, or $6.5 billion. But the benefits, perceived benefits, why we put alerts in place to begin with is because there was a perceived benefit around alerts for preventative care, alerts for chronic disease state management, and reduction of adverse drug events. And if we saw the benefits of the alerts, there'd be a $371 billion cost savings, or $24.7 billion per year. So that's more in cost savings than the amount spent. So that seems to suggest useful for return on investment. This was from a hospital perspective, and it was an evaluation at 4 community sites. 2 hospitals were in Group A and 2 hospitals were in Group B because they had different CPOE systems. And the main outcome that they looked at was adverse drug event reduction. They did a pre-post evaluation of 800 randomly selected charts, used cost data available in the literature, did an evaluation over a 10-year period, and realized that Group A spent about $83 per admission, or $7.1 million for implementation, and Group B spent about $19.3 billion. The cost avoided from reduction in adverse drug events was 7.9 for Group A and 16.5 for Group B. And overall, this was driven by the number of ADs that were averted in their pre and post evaluation. So Group A would have had an 8.3% return on their investment and would have broke even by year 8, and Group B would not have. So some variation in those results. Then this is an evaluation of technology that's implemented within the ICU, and basically looking at different outcomes. In this particular one, I focused on cost, and there's 14 studies here that looked at technology that's implemented in the ICU that had an evaluation of cost. And 6 of these, the ones that have an asterisk next to them, red asterisks, were CPOE plus clinical decision support. The other ones were either just CPOE or some other form of technology. And you can see here that the ones that had a cost reduction oftentimes were the ones that had CPOE plus clinical decision support. So 5 of the 6 studies that looked at costs around CPOE plus clinical decision support showed a cost reduction, suggesting there may be a return on your investment from implementation. So overall, basically, there's a high upfront cost. It's a long-term investment. These studies did somewhat focus on adverse drug events as their main benefit or outcome, not by design. That simply were the data that were available. There is some suggestion that clinical pathways has a good return on investment. And overall, none of them really looked at fatigue, and that probably has some cost associated with it. Just in conclusion, choose your clinical decision support wisely. Have a quality improvement project quality improvement plan in place that allows you to modify your alerts. Be cautious if you reduce the number of alerts too low, that could result in some negative consequences. This is a long-term investment, and that basically future studies should focus just beyond reduction in alert quantity and think also about other standardized metrics for looking at alert fatigue. Some of the studies I mentioned were from primary care practices or for the hospital in general. We do need more studies that evaluated it in the ICU. Overall, the task force felt it was necessary to include those because there was a lot to learn from those practice sites that could be applied to the ICU. So that concludes my discussion for today, and I'd be receptive to answering any questions.
Oh, thank you, Sandra. That was certainly enlightening to me. I think I'll take a little more time rather than just clicking through the alerts. But having moderated both sessions between the alarm and the alert fatigue, it seems that these are not simple problems and very complex, and I think we first need to figure out how best to study them before we can answer them, it seems. We do have some questions, but let me start with sort of a basic one. How best would you direct an institution to look at putting in some sort of alert fatigue management strategy?
So if I were going to suggest some way to put in alert fatigue management strategy, I start by saying, look, what we have a tendency to do here is find a problem, think we can solve it with an alert, so we put that alert in place, and I call it we set it and forget it. Right? We don't ever go on to evaluate how well that alert performs. We don't find out what a nuisance it is to the clinicians, and we don't make any modifications in it. And I don't think it can be that simple. It has to be about putting an alert in place, evaluating how well it performs, and then making modifications so you can get a highly performing alert so we can get to that place of greater than 70% accuracy in alerts to identify a clinically relevant situation and allow the clinicians to have some confidence in the alerts that they're receiving.
Right. I think that that's kind of the crux of the problem. From reading another question from a viewer that wanted to compare what is the difference between the alert fatigue and the alarm fatigue, and is the measurement different for the metrics that we use to measure it? I guess what he's trying to get at is between how the clinicians and the staff respond. Is it the same? We hear so many bells and whistles, we just ignore it, and we get so many alerts trying to put in orders, we just say we just need to get through the day.
Right.
Do you have any thoughts on that topic, or
yeah? So as a group, as a group we discussed in the metrics, and I provided some basics here in this discussion. And when the manuscript is in print, you'll see a longer discussion around the alert metrics. And we as a group believed that the concept for measuring desensitization, for measuring if the alert or alarm was appropriate or inappropriate, should it have been overridden or should it not have been overridden, was there value in that alert or alarm, is the same between alerts and alarms. So while you're changing the term alert and alarm, you would still measure those things in the same way. Because a lot of times we get so many alarms in the ICU that it's creating a lot of noise, but a lot of them aren't necessarily useful. And so what we want is alarms and alerts that have value, that identify a clinically relevant situation.
Who do you think is best tasked with deciding? Is it the clinician? Is it an outside body? Is it administration to decide which alert or alarm is important and should be addressed or should be ignored? I think that, speaking from the clinician side, certainly some of them we can recognize that they need to be addressed, but we feel we don't need to address them for whatever reason we may have, versus that may not be what JACO or some governing body thinks needs to be done.
Right. It has to be an institutional commitment to begin with, right? Because you're going to have more resources dedicated to a quality improvement program that allows you to evaluate these events. And then the end user has to be involved. It can't just be, I'm doing this just based on these data alone. It's, you need more detailed information about why the clinician overrode it. Did it make sense? Maybe they wouldn't have overrode it if it was tweaked just slightly. And so it has to be that same group of individuals where we do any type of a good quality improvement project, those individuals involved to help decide which alerts and alarms would be useful.
Great. All right. Well, let me end with two points. First, one, if anybody has further questions that they come up with offline, would we be able to have access to an email that we can send them to you and you can answer at your convenience? That would be helpful. We did that the last time. And then finally, I guess the big question would be, if an institution wants to solve their problem by just turning off the alarms or the alerts, what do you think to that?
Yeah, that is an interesting one, because it had actually been proposed in some of the literature. These aren't useful. We're just going to get rid of them. Please keep in mind that we put them in place to begin with because there was some utility. There is data that shows that they help with reduction in adverse drug events. Alerts help with management of chronic disease and preventative care processes. We're using more alerts around early warning signals, and we're putting them in place because we believe they're useful. So to completely turn off alerts or alarms doesn't seem to make sense. But I definitely think we have good ways to go to improve them so they are highly performing and we find utility in them.
Yeah, I think that's the key point, is that this isn't something that can be completely ignored, but we definitely need to refine our system. So with that, I'd like to conclude. Thanks, Sandra, for her excellent presentation this afternoon. And again, remind everybody that a recording of today's webinar will be available on FCCM's YouTube channel at youtube.com/FCCM500 within the next 3 business days. So with that, I'd like to say good afternoon, and thanks everybody for tuning in.
Thank you.
Thank you.